Good afternoon. Thank you for attending this month's OCHIN Grand Rounds. I am your host, William Pinnock, and today I could not be more excited to have Dr. Elliot Tolbert, Rose Gunn, and Lindsey Haase of OCHIN here to present Rapidly Integrating Virtual Care, Findings from OCHIN's HCCN Learning Health System. Dr. Elliot Tolbert is an evaluation and analytics supervisor at OCHIN. He has a PhD in health services research and has experience in mixed methods and survey research. He is particularly interested in finding innovative solutions to promote health equity and reduce health disparities. Since joining OCHIN in 2020, he has taken on evaluating internal and external programs, as well as many virtual care offerings. Rose Gunn is a qualitative research associate who has spent a large part of her career focusing on understanding implementation strategies, health information technology functionality, and organizational structures that affect health and well-being. She has an MA in anthropology and has a firm belief in the exceptional potential of anthropology to provide insight into the ways we conceptualize health, illness, patient experiences, and healthcare team dynamics. And Lindsey Haase is the HCCN Executive Director at OCHIN. She has served OCHIN within a variety of roles since 2012, helping the organization grow in the areas of business services, operational excellence, and member engagement, and is currently responsible for the overall federal programmatic leadership within the organization, which includes leading OCHIN's HRSA-funded Health Center Controlled Network, HCCN, which you'll be hearing about today, and other HRSA and FCC-funded programs. These programs enable community health centers across the country to leverage health information technology to provide greater access to healthcare and remove barriers to underserved patients in achieving better health outcomes. This session is being recorded. Attendees are muted upon entry, but if you are not, please mute your microphone and pose your questions through the chat or Q&A box. This presentation will last approximately 45 minutes, with 10 to 15 minutes at the end to answer any questions you may have. We will now pass the mic to Lindsey Haase, Rose Gunn, and Dr. Elliot Tolbert for Rapidly Integrating Virtual Care, Findings from OCHIN's HCCN Learning Health System. Rose, Lindsey, and Elliot, the microphone and share button are yours.
Great, thank you so much, William, for that wonderful introduction. I'm going to go ahead and share our screen here. Can you see it?
I can see it.
Thank you very much. Well, good afternoon, everyone, and thank you so much for attending our presentation today on Rapidly Integrating Virtual Care, Findings from OCHIN's HCCN Learning Health System. So we're going to start out today with an overview of OCHIN's HCCN. We're going to go into the story of rapid virtual care implementation at OCHIN, and then we're going to share our evaluation of the implementation efforts. And we will, of course, save some time at the end for questions. In the presentation today, we hope that attendees will learn about HCCNs by exploring how OCHIN's HCCN operates, how virtual care was rapidly implemented through OCHIN's HCCN during the COVID-19 pandemic, and how OCHIN evaluated its rapid virtual care implementation processes to promote ongoing improvement efforts and inform next steps. As William so eloquently presented us already to you all, I just wanted to say again, here are your intrepid presenters today. We have Lindsey Haase, who's the Executive Director of HCCN, Elliot Tolbert, the Evaluation and Analytics Supervisor, and me, Rose Gunn, Qualitative Research Associate here at OCHIN. Just real quickly, we have no conflicts to disclose, and the evaluation activities reported in this presentation were reviewed by OCHIN Compliance and determined exempt from IRB oversight. And we just also wanted everyone to know that this project is supported by the Health Resources and Services Administration of the U.S. Department of Health and Human Services. And through the use of these funds from the total annual award of the amount you see on the screen here, and the content are those of the authors and do not necessarily represent the official views of nor an endorsement by HRSA. So with that in mind, I would like to hand the floor off to Lindsey. Lindsey, take it away.
Thank you, Rose. I'm very excited to be here. If you don't mind going to the next slide. My intention is to give our audience an introductory course to what HCCNs are, Health Centered Controlled Networks, a little bit about our funder, and what OCHIN's Health Centered Controlled Network looks like. So for those of you who are not familiar with health-centered controlled networks, they're collaborative groups. There's about 50 of us across the country that are addressing the operational and clinical challenges of community health centers with health information technology. Our funder is HCCN, and we'll go into a little more detail about that on the next slide. And OCHIN received its first health-centered controlled network award in 2012, and we are the largest one in the country today. Our health centers who participate in our network receive no-cost resources as well as access to tools and training and technical assistance in the areas of patient and provider satisfaction, increasing and advancing interoperability, and then using data to enhance value. Rose, next slide. A little bit about our funder. Our partner really is the Health Resources Services Administration, also known as HRSA. They're an agency within the U.S. Department of Health and Human Services, and they provide programs for equitable healthcare and really addressing the geographical, isolated, or economically impacted and medically vulnerable. Their mission is to improve the health outcomes and achieve health equity through access to quality services, a skilled health workforce, and innovative and high-value programs. HRSA also supports the training of health professionals, the distribution of providers to areas where they are needed and most underserved, and improvements to our overall healthcare delivery system. Next slide. So OCHIN's HCCN consists of 97 participating health centers. That is community health clinics across the country that have multiple sites. We're collectively, our 97 health centers actually have over 900 sites across the country. This group is not just OCHIN Epic. If you're familiar with OCHIN, our health centers are on a diverse set of EHRs, which include NextGen, Athena Health, eClinicalWorks, EMDS, Epic, GE, and Interg. And you can see the spread of our program with the count of health centers in each state here, which is nicely laid out. We're in 12 states currently. Next slide. So not really what is OCHIN's Health-Centered Control Network, but who is OCHIN's Health-Centered Control Network? We really operate as a learning laboratory, and we're really encouraging the collective thinking, problem solving, and adaptation to the issues that are at hand in the environments of our health centers. What we offer our participating health centers are on-demand resources, which may include recorded live trainings, webinars, and videos. We also have a dedicated SharePoint portal to house all of these resources and useful tools for them. We've offered vaccine support around COVID. And then we have some really great innovation to impact toolkits that I know Rose will be talking about. We really encourage the timely peer-to-peer support across the country. We offer performance improving scorecards to our health centers. We've really incorporated change management as a basic skill to deploy out to our health centers to help them adapt to the changing technology needs and requirements within their clinics. And we do offer some specialized work groups for specific topics. We also, in our training and technical expertise, we offer customized security risk assessments to keep our health centers' data and health information systems secure. We offer support around interoperability, that's the exchange of data from one health system to another. We apply optimization techniques and trainings to their electronic health record systems so that they can better utilize it. And we also offer training and technical expertise around their data analysis that's ultimately supporting population health and improving outcomes at our health centers. Slide. So I heard in the title of this, we're talking about OCHIN's HCCN learning system, and this is really great. This is something that our program's been building on since we incepted it in 2012. We've really broken down our activities into three main categories. The first being analysis and evaluation. This is really where we look at what's happening, look at the data, look at the environmental factors, and consider what we can learn to move into the other areas of the HCCN, which next would be the innovation and implementation area. We're really looking at how we can improve the outcomes and the experience of our health centers based on what we've learned in the analysis and evaluation. And since this is such a great Venn diagram, the next piece that overlays in this is the training and technical assistance. So taking what we've learned, showing what we've improved, we then embed that within our training and technical assistance to see what we can offer based on our learnings to strengthen our health centers. So together, this is a really great system that is always learning, building, and growing from there. So this topic that we're here to hear about today, the virtual care, is a great example of how we've deployed that. And I'm really excited that we'll be talking about that. We can go to the next slide. Just a little more context. So our funded award from HCCN is a 3-year project period where we've been given 9 objectives to help our health centers in the key areas. This includes patient access, which is really using their patient portals to work with their healthcare teams. Digital engagement, you can see here in this table, on the far right, you can see our baseline is that August 2019, the percentage of our health centers where we started when we started this award. And as of the close of October of 2021, you can see we've increased patient access through patient portals by 300%. Currently, 16% of our participating health centers, which was only at 4%, have 50% or more of their patients using the portal. You can see the largest growth we've actually had and why we're here today is on digital engagement. We had 4% similarly there, and today we have 74% of our health centers that have deployed digital tools to communicate with their patients, which might include virtual care, remote patient monitoring, secure text messaging. The growth is no doubt due to the COVID and the public health emergency. However, the increase has just been phenomenal. The other areas that we've also been working on is increasing provider satisfaction by reducing their burdens. Data protection, that's the security risk assessment, cybersecurity, health information exchange, getting data in and out of different health systems so you can do whole patient care. Data integration, similar, but it's actually bringing in outside data into the records. Data analysis, using data smart to make informed decisions about operations, patient care, really preparing our health centers for the transition of value-based care that we're all moving towards. And then social risk factor intervention, also a large growth here. This is the percentage of our health centers that are using social risk factor data to inform care. So collection, screening, and then actually using that data to make decisions. And then applicant choice, each health center control network with the support of their health centers was able to determine an area to focus on. And we're using data currently to respond to substance use disorder, behavioral health, and chronic disease management. And then just some highlights over on the left side of this slide is what we did in the grant period of 2021. And you can see we've done over 8 evaluations, provided over 17 hours of dedicated one-on-one support with our health centers. We developed and published 6 new toolkits. Rose will also be speaking to that. We made on-demand video vignettes when the pandemic hit. We soon realized we were no longer able to go on site and do intensive trainings, and there's not capacity for that. So that was a great innovation we've been able to do. We've offered work groups and pilots and also office hours. And Rose, next slide, we might be at my last slide here. So I'm going to turn it back to you.
Great. Thanks so much, Lindsey. Appreciate that. My name is Rose Gunn, and I get the luck to be able to share with you today the story of rapid virtual care implementation through our HCCN. So what do we mean when we use the term virtual care? It gets batted around a lot, and we think it's very important to have a shared language. Many terms have been used to refer to health telecommunications like telehealth, e-health, telemedicine. For this presentation, when we use the term virtual care, we're referring to the use of information and telecommunications technology in healthcare delivery for a specific patient involving a provider across distance or time. So examples of this can include virtual office visits. They can include patient portal use for monitoring records, and communicating with care teams, and also remote patient monitoring, such as glucose monitoring or blood pressure monitoring. So the research literature shows that virtual care is beneficial for patients and healthcare teams alike by expanding access, facilitating the exchange of information between care teams and patients, and supporting healthcare delivery. Before COVID, virtual care had always been a little slow to change. There are a variety of reasons for this, such as provider and patient willingness. There's accessibility issues. There's regulatory or reimbursement restrictions. This was true for both OCHIN clinics and HCCN clinics. So OCHIN's HCCN had been working really, really hard on improving patient access and engagement with lean gains. Then something happened in March of 2020 that changed all of that, to Lindsey's point. So the COVID pandemic really created an opportunity to leverage some of the existing HCCN quality improvement structures to boost this virtual care adoption. So while the necessity is the mother of invention, having this virtual care QI framework in place really helped with the foundation of what would be a huge implementation effort. So at this time, we were presented with this really unique challenge in developing a rapid implementation workflow that supports OCHIN Epic member health centers, as well as the HCCN health centers. And as Lindsey mentioned, a third of our HCCN health centers don't use Epic. So there was a lot of opportunity to assist these health centers in finding what would work best in their setting. So here's a very broad outline of this approach. First, all of the available options were researched. This included options for patient portals. We looked at all the options for video visits, for automated texting, remote patient monitoring, e-consults, and e-visits. We know that what works best for OCHIN Epic member health centers doesn't work for others on different platforms. And so it really was not a one-size-fits-all approach. And the work really required taking into consideration these 10 different EHR platforms. So in addition to all the new tools and documentation required for each, implementation support was also provided for the health centers. And it's really worth noting that there were certainly a lot of technical aspects that went into the efforts. And we were able to make many documents and trainings EHR agnostic using a user-centered approach. So these fundamentals of virtual care were made available to HCCN health centers, along with an enormous amount of elbow-to-elbow support or technical assistance. I'm going to talk about that more in just a minute. So specifically, here are some of the ways in which OCHIN's HCCN supported this rapid virtual care implementation. And I want to note this before this presentation, it makes me wish that we could do another presentation on this, because it could take hours to talk through all of the incredible work that was done in this process. This is just a really high level snapshot of all of the implementation work that we did. So the rapid sprint of virtual care integration really happened in the first 60 days of the pandemic. And we mean integration in this context because in most cases, it's like adding an application into the EHR. It's being integrated and connected in such a way that it's easy, ideally it would be interoperable, though that's not always the case. This was more specific to the OCHIN Epic health centers because of its complexity, but once these non-OCHIN health centers chose the applications they wanted to use, the HCCN was able to provide subject matter expert time and support to help them really think through getting the leadership buy-in and championing, I might have a really hard time with that word, championing that work. So there, like I mentioned before, there was an enormous amount of elbow-to-elbow support to then help these HCCN health centers implement the changes through workflow mapping. There was the provision of toolkits, and you'll see on the right side of the screen here, these are just a couple of examples. We had there's an optimizing patient portal, digital patient engagement, and remote patient monitoring. Those are just some examples of those toolkits. And through the HCCN, we also developed on-demand training to videos. There was peer-to-peer learning work groups. We also provided one-on-one training and technical assistance to improve patient portal functionality and adoption rates, Q&A webinars, and of course, office hours. And again, please reach out to me after the presentation if you have more questions about this, because there was so much more provided than just this. This is our high level. And Real quickly, before I pass the floor off to Elliot, I just wanted to just share this data slide. I absolutely love this slide. This is the number of completed in-person and telehealth encounters at HCCN member clinics who use Epic. This was from October 2019 to September of this year. And it's really a nice slide because it shows the incredible uptick in telehealth encounters right when COVID came on the scene. This is current, like I said, through September of this year, and it's really shown how it's been sustained over the last year and a half. And I'm going to leave you today with a quote. This came from a subject matter expert, periodic reflection, which is a form of rapid qualitative data collection. Every few months, the HCCN analysis and evaluation team would sit down to briefly chat with all of the HCCN subject matter experts about what's going on, what's working well, what can be improved, what their unique adaptations were. And this really helps us to understand the implementation from both a longitudinal perspective, but also helps with immediately supporting the needs of OCHIN's HCCN subject matter experts. So this one is from a subject matter expert in May of 2020. So this idea that you could just roll out technology, even with some efforts to improve it, that is an ongoing process. That process will never end. While we have more members and participants of HCCN using it, we continue to hear about ongoing barriers. We will address what we can, whether it's through improved documentation, enhanced technology, maybe a different partnership. But it really does boil down to having the time and space to take a deep breath and say, all right, since you've implemented, how is it going now? And we chose this quote because it's a great segue to our next presenter, which will be led by, this is Dr. Elliot Tolbert. Elliot, go ahead and take it away, please.
Thank you, Rose, and thank you all for joining us here today. And as Rose said, I get the pleasure of sharing how we evaluated this rapid implementation of all of these virtual care tools. So with that, next slide, please. So we broke this evaluation into two major parts, which you can see here. The first one under objectives is evaluation of virtual care implementations. And the second one, a little further down, is the digital divide evaluation. And so what the first part did was it looked at the actual implementations themselves and determined the long-term adoption and impact on healthcare and health outcomes. Now, the digital divide evaluation was a little different in that it examined the impact of COVID-19 on the primary transition to care. It looked at the populations that could have disparities when it comes to virtual care access. And finally, examined the promising practices and barriers as they relate to virtual care access. For data collection, we had multiple approaches here. So quantitative data came from the HCCN sites telehealth reporting metrics. And so all of the participating sites provide data to us on a regular basis. And so we included the telehealth reporting for quantitative data. We also looked at data from the Advanced Data Warehouse, which is a collaborative of data from different healthcare organizations. And for that reason, this was limited to the OCHIN health centers. The qualitative data came from semi-structured interviews, and this took place with 13 participants from throughout the OCHIN HCCN collaborative. And in addition to that, an open-ended survey with closed-ended questions, so mixed method survey was available to HCCN collaborative participants as well. And when it came to our analysis for quantitative data, we did statistics, and the coding that took place for qualitative analysis was inductive. Slide, please. So what did we learn? So the first part, the evaluation of virtual care implementations, we have the major takeaways laid out for you here. The first one is that the themes between the survey and the interviews were consistent. So one kind of validated the other. A major takeaway, the first one here, is that the EHR system played a large role in how sites implemented and used virtual care. So we heard from Lindsey that, and from Rose, that the sites that are participants may be on the OCHIN Epic EHR platform, or they may not. And so I heard this in interviews from participants about how the platform where they provide EHR provided different experiences. The sites were generally able to overcome major barriers, and minor barriers result in ongoing challenges. We'll see in detail in the next couple of slides about how those barriers played out. We heard that participants had uncertainty when it comes to the future of virtual care due to societal factors. The main issue with this is the payment mechanisms. We don't necessarily know based on federal or state regulations what the payment structure will be for virtual care in the future, and we heard that during these interviews. And finally, barriers and facilitators emerged in 3 different areas, and so these will come up in the next slide, but it was the clinic, clinician, and patient levels. And finally, we have a qualitative insight here from one participant who talked about how tech issues could lead to failed virtual visits. So they say, I'm not very tech savvy to actually, help them through their technical issues real time. So it's easier for me as a clinician to just say, well, let's just convert it to a telephone visit. Slide, please. So here we get into the barriers for the first evaluation. This is the virtual care implementation and use. And so at the clinic level, we can see we heard lack of staff being able to provide training, support, and troubleshooting. And this is for clinicians and for patients, because as we heard, clinicians are not necessarily tech gurus. We also heard that there was a lack of flexibility when it comes to desired features and the healthcare offerings that were provided. This speaks to the differences we heard based on the EHR platform that the participants site used. For OCHIN Epic participants, this was a situation where the features and the virtual care offerings in general were embedded into the Epic platform, so they didn't necessarily have flexibility when it came to the offerings that were provided. We also heard that there was a lack of knowledge regarding patients' virtual care capabilities, and having to switch among various virtual care platforms. This goes back to 2 different types of EHR systems being used, actually multiple types of EHR systems being used. For those who were on the non-OCHIN Epic platforms, they spoke to having more freedom when it came to deciding which virtual care offerings they wanted to incorporate, but then that kind of opens the door for going down a path where you have to switch to a completely different platform if things don't work out. So flexibility on one hand, but then that flexibility could lead to uncertainty. And across the board, I heard that rapid implementations due to COVID-19 in general were difficult, because having such a mass implementation in a health organization is typically not what they're used to. So this was not an easy undertaking. At the clinician level, a lack of knowledge and experience using virtual care platforms was expressed. And this is what I spoke to also at the clinic level. Lack of troubleshooting skills and support to address technical issues before or during a virtual visit. So this came up because some sites had resources and capacity to beforehand, I would say, bring somebody in and make sure that a patient could log into virtual care and complete a visit. Other sites did not have resources and tools available to do that. And so it took OCHIN and HCCN stepping in to provide that support. But if it happened during a virtual visit, we heard that this could be the most detrimental outcome, because this is when the clock is ticking, you're expected to complete a visit, and if it fails, you are left, you could be left out in the cold. Incorporating virtual care into specialties that typically depend on physical examination and procedures. This would be in dentistry, for example. I spoke to a clinician that was still expected to provide visits by virtual care. So you could imagine how getting a tooth examined virtually could be difficult. Failed virtual visits reverting to phone calls. And this came up a lot because if something did inhibit a virtual care visit that was taking place via a platform, the best case scenario at that time would be to just complete the visit by a call, which may not always be the best process. At the patient level, we heard there was a lack of access to technological devices, lack of access to high-speed internet services. The language that the patient preferred or their primary language could be other than English, and there could be a lack of knowledge or experience regarding technological devices and internet. And a patient may have low buy-in, and this could be because the patient does not see virtual care or virtual platforms in general as being trustworthy or being effective ways of providing care. And slide, please. So the facilitators, when it came to virtual care implementation and use at the clinic level, would be if a clinic had the capacity to provide additional support and resources, and that would be in the areas I just spoke to. Some clinics are able to either bring on new staff or adjust their current staff to take on roles that they wouldn't have normally taken on before. And this could be getting patients enrolled in MyChart or another type of patient-facing platform to complete virtual care communication or visits. The next level here at the clinician level, the easier the virtual care experience, the easier it was to have the buy-in from staff and patients. And so I heard from a lot of providers especially that if this process to get a patient onto virtual care included multiple steps like downloading different platforms, downloading applications, the more steps that were included, the harder it was for patients to have that buy-in. So the easier you can make it for the patient and the staff, the better it turned out. And then finally, at the patient level, using workarounds to meet the patient's virtual care needs. And the most straightforward example of this would be reverting a virtual visit to a phone call. So the second evaluation, the digital divide evaluation, these are the major takeaways as far as our findings. So similar to the previous evaluation, the survey and the interview had some similar results. The EHR, again, played a major role in how sites addressed an implementation and use of virtual care. Themes for the digital divide came up in three areas. So technical issues, a language barrier, and patient apprehension. Race and ethnicity was not referred to in neither the survey nor the interviews, but what did come up was rurality. We'll get into that in a second, as well as age, and age also emerged as a primary contributor to the digital divide. Down here, we have another qualitative insight, and this one gets into rurality and the lack of broadband access. This participant says, the difficult part is the patient demographic that we have is very rural. So, you know, a lot of the connectivity or broadband that our patients have is sometimes limited to their phones. And slide, please. So here we have the barriers contributing to the digital divide. For the patient technical issues, we heard lack of access to technological devices, lack of knowledge and experience when it comes to these devices, difficulty when it comes to virtual care adoption and procedures, and technological failures. So a lot of similar things that we heard from the first evaluation came up here. The patient language barrier was a major one. And so this is a situation where in a face-to-face office visit, you could bring in a translator to complete that visit, but in a virtual care setting, there were some participants that spoke about an additional platform. And so there's another step involved in the virtual care completion, bringing in an additional person to act as a translator on a virtual care visit. And that wasn't always easy. So this created major barriers in those regards. And finally, patient apprehension. So we heard about patients being apprehensive about using high-speed internet. They may not be comfortable using virtual care tools or afraid their information is not private, or they may not see virtual care as an optimal healthcare solution. And slide, please. when it comes to the facilitators to overcome the digital divide, patient technical issues, we heard that if a site was able to attain funding to purchase devices for patients, they were in a better situation because they could at least have the tool needed to complete virtual care visits. The capacity to provide patient technical assistance. This would be a situation where, as I spoke to earlier, a site could either hire new staff members or adjust their roles to be able to provide virtual care. Providing platform preferences for patients. And this gets to some of the issues where patients may not be comfortable or familiar with technology. So if you could provide something where they could click one button to participate, it resulted in more success. And the ability to simplify highly technical processes. So again, simple is better. The patient language barrier, this was alleviated at clinics where they could use workflows to break the language barriers. And so those workarounds that I spoke to earlier were good examples. And the one I would add to this would be, there was a particular provider that was using, I think it was Google Translate to speak to a patient. And so the patient luckily had a family member that was nearby that could come in and act as a translator. And so they were able to complete the visit, but there's still room for improvement when it comes to the language barrier. And finally, patient apprehension. Clinic specialties like behavioral health, these providers actually spoke to how they managed to thrive in this virtual care environment because patients were comfortable receiving care in the comfort of their own homes in this situation. And virtual care may relieve patient burdens. So providers talked about how transportation, childcare were alleviated through virtual care. And slide, please. So what were the recommendations provided based on all of the findings that came out of both of those evaluations? They are provided here. So starting from the top, providing EHR-specific support information and workflows. And this really gets down to the type of EHR that the site is using, their patient populations, their clinics, and the specialties that they provide. Expand evaluation efforts to further examine and address the barriers and to implementation and use. So I spoke to a lot of the barriers and the to implementation and use in the previous slides, but there's always room to continue these efforts, and that's what we're doing now and will continue to do. Disseminate learnings internally and to all the stakeholders that are involved when it comes to virtual care. Expand language capabilities in virtual care tools and expand access. Provide solutions and troubleshooting support. And this is to help those providers as they come into these technical barriers. This is before or during a virtual care visit. Expand training and resources to support providers' abilities to use virtual care tools. Influence virtual care policies and monitor implications. And so this is a situation where OCHIN and the HCCN could keep a handle on what the political and societal directions are when it comes to virtual care so that a clinic doesn't have to take on that additional burden. Create an assessment tool to capture patients' technological capabilities. This is about finding out where your patient population is and being able to provide services that meets them, that are able to meet your patients where they are. Assist sites by providing information about funding opportunities. And this is major because the participants talked about not having devices or not having resources, and there are funding opportunities that OCHIN has tapped into for things like remote monitoring devices. And this is an opportunity here for OCHIN and sites to expand virtual care through opportunities like that. And providing additional opportunities for PHCs to participate in trainings and work groups. And Lindsey spoke to a lot of the work groups that HCCN has in place. Rose spoke to them as well. And so this is getting sites involved in those trainings so that we can all be on the same page as far as what's available. Slide, please. The recommendations at the clinic and clinician level, the first is to promote virtual care among members of site leadership. So we heard from providers that if there was buy-in in the organization from the top all the way down, virtual visits and care in general were more successful. And again, we want to look at patients' technological capabilities along with the capabilities of clinicians and providers. We want to assess clinicians' experience and capabilities regarding different virtual care platforms and forms of technology. Expand virtual care platform language access in order to provide virtual care materials in various languages. This is something that OCHIN has tapped into, and currently when it comes to providing different languages, working with sites to see which languages are missing and making sure that we're not leaving anybody behind. Obtain and address patients' preferences and perceptions of virtual care. So this gets into that patient apprehension question and what we can do to see what questions patients have. So providers said things like, I don't know how to talk to a patient about how safe a virtual care visit is. This is an opportunity for OCHIN to partner with clinicians to make sure that information is conveyed to patients. Participate in OCHIN's work groups that aim to address virtual care implementation and use. And again, this gets into a lot of the services that OCHIN and the HCCN are able to provide. And finally, those funding opportunities that advance virtual care implementation and use. So seeking funding either at the clinic level or partnering with OCHIN and the HCCN to do so. And next slide. So we are at the conclusion. OCHIN's HCCN rapidly implemented virtual care in the early months of the COVID-19 pandemic, and the multi-component implementation strategies offer health centers a right fit approach tailored to their setting. Evaluation is important. It's an important component of learning health system to foster continual improvements. And future research should explore how to best support patients in utilizing virtual care. And before we close out, we'd like to acknowledge the the superhuman efforts of the HCCN community health centers to continue to provide high quality, patient-centered care in the midst of a global pandemic. We are grateful for their flexibility and their ability to innovate on a dime. And we'd also like to acknowledge that this work could not have been possible without the efforts of the HCCN team and everyone that is listed here. And we thank everyone for your time.
So I want to thank Dr. Tolbert, Rose, and Lindsey for that fantastic presentation. And thank you to everyone who attended today's session. Be sure to follow OCHIN on Twitter at OCHIN Inc. and over on LinkedIn. In addition, head over to ochin.org and advancecollaborative.org to read the latest on our research studies, blog posts, and upcoming events. And don't forget to check out our OCHIN YouTube channel to catch up on past Grand Rounds presentations and everything OCHIN. And OCHIN Grand Rounds will be taking a break during December, but we will be returning on January 12th in collaboration with the Bridge C2 Center out of Oregon Health and Science University and in honor of Cervical Health Awareness Month with Dr. Patricia Carney of OHSU presenting Partnering with Rural Primary Care Clinics and Local Communities to Eliminate Disparities in HPV Vaccination. Invitations to this event will be sent 2 weeks prior to the event, but if you are not on our mailing list and are interested in attending this or any future event, please email me at grandrounds@ochin.org. That's grand rounds, all one word, grandrounds@ochin.org. So from all of us at OCHIN to all of you, have a wonderful rest of your day and stay healthy out there.